So our keynote speaker for the day, Aparna Taneja. She's a researcher at the AI for Social Good team in Google Research India. She collaborates with several NGOs and academic partners in the fields of public health and conservation. And her primary focus is the collaboration with Armaan, an NGO that's focused on improving maternal and child health outcomes in India. Aparna joined Google in 2015 and worked with the Google Maps team in Zurich to improve search quality for maps. She received her bachelor's and master's in computer science from IIT Delhi and her PhD in computer science at ETH Zurich under the supervision of Professor Mark Polyfees. She then pursued her postdoc at Disney Research Zurich. So that's Aparna. She'll be delivering her talk remotely. Thanks, Aparna. I know it's not easy to do with sick kids, but appreciate it. So, the widespread availability of cell phones has enabled nonprofits to deliver critical health information to their beneficiaries in a timely manner. In the keynote address today, Aparna will describe the AI work to assist nonprofits that employ automated messaging programs to deliver timely preventive care information to new and expecting mothers during pregnancy and after delivery. A key challenge in such information delivery programs is that a significant fraction of beneficiaries end up dropping out of the program. Yet, nonprofits have limited health worker resources and time to place such crucial service calls for live interaction with beneficiaries to prevent such engagement drops. And to assist nonprofits in optimizing their resource, a Restless multi-arm bandit system was developed for optimizing such service calls to beneficiaries. And they've been able to show the improvement in engagement behavior with the program with the help of a real-world study involving around 23,000 participants.
Today, I'll be talking about, in particular, one collaboration with Armaan, which is based in Mumbai, and their mission is to improve maternal and child health outcomes. Next slide, please. Currently in India, a woman dies in childbirth every 15 minutes, and 2 children under the age of 5 die every minute. Next slide, please. And access to timely maternal health information can save these lives. These deaths are preventable only if people have access to the right information. And as Dr. Aparna Hegre, who's the founder of Armaan, says, pregnancy is not a disease. Childhood is not an ailment. Dying due to a natural life event is just not acceptable. Next slide, please. So as we mentioned, Armaan is an NGO that focuses on improving maternal and child health outcomes. They currently operate in 19 states in India, have already served over 26 million women, and they have a big network of over 200,000 health workers, 97 partnering hospitals, and 40 partnering NGOs. Next slide, please. They run a variety of programs, especially mobile-based health awareness programs, one of which is the M-Mitra program. Now, the M-Mitra program sends 101 automated voice messages to pregnant women and new mothers from the underserved communities. So typically, for instance, a new mother or a pregnant woman would receive a message every week saying, you're in the 3rd month of your pregnancy, it's very important to take iron tablets, or you're in the 6th month of your pregnancy, please don't lift heavy stuff, go for checkups, etc. And the importance of listening to these messages is known to have great positive impact on health outcomes. For instance, 17% increase in infants with tripled birth weight at the end of the year, and 36% increase in women knowing the importance of taking iron tablets. Next slide, please. However, Armaan faces a key challenge. Up to 40% of the women stop engaging with the program over time. To avoid this, they have a system called service calls, where a health worker will actually physically call a woman on a phone and engage and ask them, why are you not listening to the calls? Is there something we can help you with? They try to convince them, explain to them the importance of listening to these calls, resolve any issues. For instance, the woman may say, well, the messages come in Marathi. I don't speak Marathi. Can I get the messages in Hindi? Or I receive the calls at 9 a.m. but I don't have a phone at that time. It's my husband's phone. Can you call me in the evening instead when he's back, and so forth. So the health worker can then make these changes to help retain these women in the program. Next slide, please. But you can imagine that on average, Armaan enrolls 25,000 women every month. And of course, physically calling women means having those resources. So let's see, if you can only make 1,000 service calls each week, then which 1,000 women do we call? Because we cannot call everyone. So this problem emulates a limited resource allocation problem, where the resource being the service call in this case. Perfect. Thank you. So typically in AI, a conventional approach towards limited resource allocation problem is solved using something called restless multi-armed bandits. These are similar to stochastic multi-armed bandits in the sense you have n arms, you have to choose m per round to maximize your reward or benefit. In this case, for instance, we have to choose 1,000 arms to call from the 25,000 beneficiaries. But key differences from restless multi-arm bandits to stochastic multi-arm bandits is that each arm has a state, and the state evolves irrespective of whether the arm is pulled or not. For instance, in this case, we know all the women, we know their engagement behavior, whether they can listen to the calls or not, irrespective of whether a health worker actually calls them or not. Similarly, also reward is collected each time step from all the arms, irrespective of whether an arm is pulled or not. Next slide, please. So each beneficiary or arm in this case is modeled as a Markov decision process. A beneficiary can be in a good state or a bad state. The state is defined by whether they've been engaging with the calls or not, and engagement is defined as if they've listened to a call for more than 30 seconds. And on average, these messages are like 1 minute long. And a beneficiary transitions from the bad state to the good state under some given model parameters, like the transition probabilities of transitioning from a bad state to a good state under active intervention or passive action, and vice versa. Next slide, please. So the active action is where a call is where a beneficiary is picked for a service call. So a health worker will call them. Passive action will be that they continue to receive the normal automated voice messages, but no service call. And the transition matrix addresses the probabilities of transitioning from one state to the other under both these actions. Next slide, please. So the restless multi-arm bandit, at each time step, it will follow a sequential decision-making problem, where given all these model parameters and the states of the beneficiaries, it will pick which women to call and repeat this for every time step thereon. Next slide, please. Now, the tricky question here is, how do we know the model parameters? How do we know the probability of a person, whether they will transition from bad state to good state upon receiving an intervention or not? So currently at training time, we have historical data from some previous studies that the NGO has conducted. So we have access to the demographic data of the beneficiaries, like their age, broadly their education, broadly income level, the language they speak, who's the owner, who owns the phone in the house, and so forth, whether they have any children or not. And we also have access to their engagement data from the past, whether these beneficiaries on average, how many calls did they listen to, and also if they received a service call, how was the behavior thereafter. Of course, data around the active action, that is after the service call based data, is very less because very few service calls are made, so very few data points exist for that particular scenario. Now, let's say at test time, a new beneficiary enrolls into the program. At this point, we don't know how they're going to engage with the program. We only have access to their demographic data, like their age, education, income, etc. Next slide, please. So how can we then learn these RMAP model parameters? Currently, what we do is, like I said, we have past listenership data and demographic data. So we perform clustering on the listenership behaviors to find out clusters of women which behave similarly. And then we have a mapping from because at test time we won't have access to their engagement behavior. We only have access to the demographic data. We create a mapping then from the demographic data to the transitions to the probability data. Yeah. Yeah, so we create a mapping from the demographic features to these clusters so that at test time, when a new beneficiary comes in, we have access to their demographic features. We then instantly know which cluster they would belong to, and potentially these are the transition probabilities corresponding to this cluster. We use something called Whittle indices to produce a ranking of women. Won't go into detail of that, but we're able to produce a ranking of which women at this particular point of time will benefit the most from receiving a service call. That is, they will start to engage with the program once they receive a service call. So we can pick the first top K, which is let's say the top 1,000 women in the case where we can only call 1,000 women each week. Next slide, please. So to evaluate this algorithm, we actually conducted a real world study involving 23,000 women. We divided the women into three groups. One group was the CSOC group, that is the current service of care, um, which is basically the default what the NGO follows right now. No special service calls are made. The women just receive their typical automated voice messages every week. Now, in general, all the women by default have the option of this missed call service where they leave a missed call and to a certain number, and then a health worker can always call them back asking, how can we help you? So that's the current service of care where no service calls are initiated by the NGO, but everyone has the option to do a missed call. The second group was our RMAP group, our algorithm, and the last group was the round robin group, where beneficiaries are called in a fixed order, one by one. So we observed that the study was run for 7 weeks long. On average, 225 service calls were made to both the RMAC group and the round robin group. So on average, total of 450 service calls each week. And we noticed that consistently the engagement of the women in the RMAC group outperformed the engagement of the women in the round robin group. In particular, RMAC performed 32% better than the current service of care. The percentage reduction in cumulative engagement over time was 32% less for RMAC group and 28% less compared to the RR group. And we also found these results to be statistically significant. The results of this study were published in a paper at AAAI this year. Next slide, please. We're able to reach out to more and more women each week and get them back into the fold and save lives because of AI. I'll play this video later. Where a mother is Pooja, a mother of 5 months old, says, "I follow all the advice and take good care of my baby." And now the plan is to actually deploy this software, hand this over to Armaan to run this on a weekly basis to generate which women should be called every week. And we plan to hopefully scale this to over 1 million mothers by next year. This work was also featured in Google for India event last year. And we're hoping to, these promising results have been wonderful and have encouraged our relationship with the NGO, and we're planning to scale this to the next program called Kilkari, which actually runs nationwide, um, and already has a 25 million women enrolled in it. So the plan is to extend the same program to boost engagement with that program as well, because that reaches a much, much, much larger scale of women. Some more interesting things we did following the study was from the women who actually received the service calls, we picked 500 women at random and asked them, you know, did these calls actually help you improve your listenership? And 60% of them responded yes, and 40% responded not really. And then we asked them, how did these calls help you? And the, in some cases, it was the logistical reasons like changing the time slot or updating the delivery date. But the biggest reason was getting more information on the Mitra program as to basically understanding why it was important to listen to these calls in the first place. So that was the biggest motivation that helped them improve listenership. Um, uh, and I'll go over this quickly. So all of this research has led to some very interesting new research questions. One of the topics we're looking into now is called decision-focused learning. This has gained importance in the recent past. So typically right now, our problem is we collect data, we use past data to learn some model parameters, that is the transition probabilities. Then we learn this mapping from the features to transition probabilities, and then run the optimization to produce the top K list of people to call. However, this is currently done in two stages, where in the first stage, we've learned the model parameters, and in the second stage, we've done the optimization to produce the list of women. Now, in this two stage, by learning the model parameters, we've definitely maximized learning accuracy, the learning accuracy with respect to learning model parameters. But our final goal is to optimize another reward, which is the engagement with the program. So there is basically a misalignment in the objective. We're maximizing learning accuracy, which may or may not be equivalent of maximizing decision quality in the end. So what decision focused learning does is we try to maximize learning accuracy while maximizing decision quality. So let me just try to explain this a little better. Let's say we have on the y-axis transition probabilities and on the x-axis some feature representation. And in the two-stage learning, what we'll do is the classifier will learn, let's say it's a linear regressor, it will just try to maximize the learning accuracy of the model. So it will predict a model like the green line here, such that the error to the total error in the end for this particular classifier is minimal. And if these red dots, let's say, represent a high transition probability of dropping off from the program if you're not called. So these are the risky profiles. That is the people which are at a high risk of dropping off from the program if you don't call them. And this is just a hypothetical scenario. This is not derived from real data. If there was such a cluster of women that were a high risk profile, now in the two-stage program, the linear regressor will try to fit it where most of the data is to minimize error, which means you would ignore these women. On the other hand, if we were to do a decision-focused learning-based regressor, in that case, we know that it's most important to actually call these women because these women are the ones that are the highest risk of dropping out from the program. So if we call on them, we we potentially have the advantage of them improving their engagement with the program. So even though it may look like it has a low learning accuracy, in the end, it has a high decision quality. And in the end, that's what we care about. We don't care about learning the most accurate model parameters, the most accurate transition probabilities. What we care about is that in the end, most of the women in the program are engaged. So in the two stage, you see that the predictive accuracy of the model with respect to learning model parameters is very high compared to decision performance, decision focused learning, but the performance of the policy, which is the engagement with the program, is higher for decision focused learning compared to two-stage learning. So this is currently in submission to a conference. And there are many more such interesting topics that we're looking at besides restless bandits and decision focused learning. We're looking into fairness, robustness of the problem. That is, we have this very interesting real world scenario of limited data where we know we have very limited data around the active transition. That is when a service call was made, how did women change their behavior? We have very few data points around this. So how do we make our systems robust to limited data, as well as how do we ensure that we are, intentionally or unintentionally favoring certain groups or not? So fairness with respect to distribution of these calls, and many other interesting research challenges. So our team had funded 6 projects in the year 2020 and it funded 30 projects in the year 2021. Armaan was one of the first projects from 2020. And we continue to have collaborations with several NGOs in the fields of public health, conservation, and agriculture. I'll end with this small video that was recorded for the Google for India event. Yeah, that's it.
reach out to more and more women each week, get them back into the fold, and save lives because of AI.
Right. Yeah, this work was done with the, sorry, wait, why is the video not? Okay, so we can stop the video, I guess. Can we? Okay, thank you. Yeah. So yeah, I would like to thank all our collaborators from both Google Research India, the NGOs that we are working with, students from Harvard University, university relations, AI for social control programs, and a whole bunch of teams. Yeah, this was done with a huge number of collaborators, so a big shout out to all of them. Thank you so much. And again, apologies for my sore throat and all the technical difficulties we've been having. Thank you.
It's a great application of AI, so thank you for sharing. I had a quick question when you talk about decision-focused learning. How is it different from decision theoretic learning? I mean, decision theoretic learning is a very old concept. Um,
Okay, to be honest, I'm not sure if that's a different concept or if it's the same thing. So decision focused learning I know has been around for a while. It's just how it's been applied to different domains, and this is just an interesting area we thought where it actually can help, given that there is a clear misalignment of the two goals that we're trying to solve.
okay,
Yeah.
okay, cool, thank you.
Hello. Aparna, wonderful presentation. I watched the Google for India presentation, but of course, they did not touch upon the data science details of it. So, thank you so much for sharing that with us today. I have one question that is about why go with an RL approach to start with? Why not stick to supervised or unsupervised or a decision focused learning, as you've been mentioning, or even Bayesian models since you're already using Markov models?
Right. So we did think about using, for instance, some deep learning approaches and so, but those rely then on a heavy amount of data. Like I mentioned, we do have in more than enough data for passive transitions, but we don't have enough data around the active transitions, how women respond to upon receiving an intervention. We did try an LSTM model as the first start, but it would produce results like 30% of the women are at the risk of dropping off from the program. Now, 30% of 25,000 is still a large number. So how do you still, come up with a ranking that says uh, which women should be called? So the accuracy wasn't great, and also another interesting thing which I didn't mention in the slides was that uh, computing resources is also a constraint. This is an NGO which is running on a limited budget. So we also don't want very expensive algorithms, which are not sustainable in the long run for the NGO. So a lightweight solution which is sustainable as well as is not very data hungry. That is one of these are the key reasons why we went for this approach.
Thank you so much.
Hi, Aparna. Uh,
Hello.
I have a question regarding the problem that we are trying to solve here. So, we are trying to improve the childbirth and the health of the baby. So here in the cities, we see a lot of postpartum problems too. So is it something that exists even in the rural areas? And if Armaan is trying to do this for the childbirth and for the health of the baby, is there some they can extend it for postpartum if it really exists there, like for the health of the woman, even post childbirth?
Right, right. Yeah, that's actually a great point. I think maybe I missed it. So these calls are meant for the first 9 months of pregnancy and then the first 1 year, 12 months post birth. So you also get calls after giving birth. In fact, I think you get 2 calls during your pregnancy every week. The first week of birth, you get a call every day. And then in the next 1 year, you will also get calls informing you about how you should monitor your health and the baby's health. In addition to that, there are other more complications, such as we're trying to now look into malnutrition in detecting early malnutrition in children, so that detect it well in time to avoid adverse outcomes later. That is another thing Armaan is looking into, and we are hoping to collaborate with them on that as well using AI.
Thank you, Aparna. Projects like this make us realize how privileged we are to have access to all the information, and this is a very nice initiative to make a difference to the lives of the women in rural areas. Thank you.
Thank you.
Hi, Aparna. Not sure if I have missed it, but do the call volume or the treatment vary across the trimester or the treatment?
So basically, these are automated voice messages, and they are custom made according to the gestational age of the women. So you will receive a different message when you are 6 months pregnant versus when you are 7 months pregnant, or 3 months pregnant, or 3 months post birth, and so on. So the content has been
And
made by public health experts. Uh, yeah.
okay. And when you talk about the transition metrics, and when you said that 60% of women said yes, it was helpful. So does it cover the entire 9 months of pregnancy, or the result would vary across trimester?
You mean the results of engaging with the program?
Yeah, so do you think that a woman who is in her third trimester might feel that this type of a call would be really helpful than in the early days of the pregnancy?
Yeah, that's a very good point. That one, listenership behavior changes over time, over your pregnancy. This is something we've noticed, as well as listening to some calls may be more important than listening to some other calls. So currently, in our model, we input, like I mentioned, we have the transition probabilities, we have a set of features, and we produce a mapping. And in this set of features, the gestational age is also used as an input, and it's one of the critical features. But we don't explicitly right now, promote calls to women who are in the later stages of their pregnancy. That is not done.
Okay.
The model decides whoever is at the most currently at a high risk of dropping off from the program and may benefit from receiving the call. So yeah.
Hi, Aparna. Thank you so much for this wonderful presentation. Last question, I think I just wanted to check. Do you also take into are features also built upon the inherent any problem, maybe something like diabetes or some other condition of the women, which will affect the pregnancies, which could be more severe in certain cases and not so much in the other cases? So, are all of these genetic factors also considered in your model?
That's a very, that's a, yeah, a really great question. There's something we've also discussed about. The issue is that at this point, we don't have access to that level of information yet in this particular setup. So the NGO right now enrolls these women through hospitals, through community centers, and through the NGO directly. And there is some basic information about how many children you had, um, you know, did you have any if they want to reveal, you had any complications in previous births and so forth. But there's very limited information around their general health history and obstetric history. There is some information, but not a lot. But that is something that will be very useful, because then you can even more better prioritize women who really are at certain risks, whether they are facing gestational diabetes or preeclampsia or other conditions which can hurt them or their baby. So this is another thing, another program we're hoping to look into, where they plan to collect much more richer information, health information around the women, such that that can also be taken into account. But so far, it's not been done.
All right. Thank you so much.
Thanks, Aparna, being sick and all. And yeah, like she still joined us remotely and didn't bail out on us. Thanks a lot. Hope you get better soon. And if you're going to be on the webinar, and if there are more questions that come your way, please do answer them. So thanks a lot. That was a fantastic talk by Aparna. And